Got it.
All right. Well, welcome and good evening to everybody. My name is Jim Frame. I'm your medical director for the course. And what we're going to talk about over the next 3 weeks now is going to be environmental injuries. I have been writing questions for the National Registry and such. I can tell you this next cycle that's coming up over the next year is going to have 4 questions on hypothermia, 2 on heat emergencies, and then there's going to be 2 questions on venomous reptile poisons and venomous snakes, essentially. The 4 is for the hypothermia, and the reason that there's 4 is because of the recent development within the country. 700 cases of hypothermia have developed within the last year, and they're all related to the 48 states. Most of the cases, and you're going to probably close one eye and scratch your head a little bit, but most of the cases for hypothermia come out of Florida. Tends to get a little bit cool down there, and when it does, people have a problem judging the temperature outside and such. And of course, there's a higher population of elderly that are down there as well. And we'll cover all that in the presentation coming up. The presentation here is 26 slides. It should take us about 40 minutes. Bear with me. I'll give you a few seconds to read each slide before I get into explaining what the slide is all about. Incorporated within the slides, of course, are the 4 questions. Of course, I incorporated 16 because for each test, and there's 5 versions that are out there, you'll get a different subset of questions. So hopefully we can hit all the high points here, and you'll have nothing else to do except review the slides and be ready for the National Registry. So we start out with a scenario that's pretty common throughout most of the 48 states down here, and more likely than not, probably Alaska as well. But the patient comes in lifeless, and the patient is found in a snowbank. And within the realm of possibilities, this could be a psychiatric patient, a drug and alcohol intoxication / overdose, or it could be an elderly person. It could also be a person who's sustained some sort of injury and fell into the snow and can't move. But you'll see in the scenario here that there's 2 really important concepts here. The first is that obviously a patient comes in with no vital signs or looks like they're dead. Can't be dead until they're warm and dead. There's no semblance here of any type of, any kind of presentation that allows for a hypothermic patient to be pronounced dead until they're warm. As we'll get into throughout the presentation, you'll be paying attention to certain degrees, what kind of arrhythmias are caused, and what kind of cardiac and neurological activity occurs at different temperatures. So you pick her up and you see her, that you put her on the stretcher, and she just turns into a ventricular fibrillation. What is the next appropriate step? So we get into hypothermia, and just to cover some of the pathophysiology here, we see that, excuse me, more heat is lost than the body can generate. And there's really 2 mechanisms that this occurs. It's either unable to generate heat or you're losing heat at a rapid pace. Some of the rewarming strategies that we'll talk about, and being cautious as paramedics in the field to recognize when a comorbid condition exists, whether they're elderly, diabetic ketoacidosis, alcohol intoxication, or some of the other patients that have had strokes, transient ischemic attacks and such, where the patients find themselves outside. You hear about stories every once in a while on an Alzheimer's unit where a patient just wanders right out of the unit, not aware of their surroundings. And of course, their perception to cold and pain and such is much diminished. And subsequently, they end up in a snowbank or outside walking around. They could very well be hypothermic as a result of the dementia. And as a result of that hypothermia, it exacerbates other comorbidities. Should a patient have heart condition or neurological disease and such, this will certainly bring it out. So let's talk about a couple definitions first. And you should know that mild hypothermia is 34 to 36 degrees centigrade. Make your own conversions on the Fahrenheit. 30, 37 degrees is considered normal, 98.6. So when you get around, 94 degrees and such like that to 96 degrees, you're looking at some mild hypothermic changes. Moderate hypothermia goes from 30 to 34. And then, of course, severe hypothermia is anything under 30 degrees. And kind of put these numbers into perspective, if you will. The reason being that there are certain arrhythmias associated with each of these degrees, and the rewarming strategies, in other words, what techniques are we going to use to treat these patients and start getting them rewarmed, is different for each one of the categories that you see here. So we have two types of hypothermia. One is primary, obviously one is secondary. The primary being the most important here, in that these are usually healthy people that end up in a bad situation. And so this kind of prolonged activity in a cold environment, these are people that are lost on camping trips, snowstorms up in the mountains, plane crashes, car accidents and such, or just plain old avalanches where they're stuck in bad situations, skiing obviously being a big one. Of course, drug and alcohol doesn't help, and subsequently drinking alcohol or taking drugs can dull your perception to temperature changes and disorientation, mental status changes and such. We see that concurrent with the homeless patients as well. You may be called to a bus station, train station, or just anywhere where they have chairs and seats waiting for buses. You see that mostly in the cities. So that would be a primary. In other words, a normally healthy person who's gotten themselves in a bad situation, as opposed to the secondary hypothermic changes, which occur in patients who have an underlying medical condition where their thermoregulatory mechanisms, which is the hypothalamus, are disrupted. These patients are typically have a comorbid situation where their senses are dulled, like the dementia patient that we were just talking about a little bit ago. But your diabetic ketoacidosis, your hypoglycemic patients, patients that have had strokes and transient ischemic attacks can find themselves in bad situations. And subsequently, when you treat the hypothermia, start to warm them up, all of a sudden you see that the patient's had a stroke, or they've had some sort of diabetic ketoacidosis situation, or anything that has to do with a primary medical condition, including sepsis. A lot of the secondary hypothermia that you see is usually an elderly person who has fallen on the ground inside their home and can't get up. Subsequently, because of their illness, they run into situations where they're on the floor for 18, 24 hours or so, or nobody's seen them in 2 or 3 days. Go to check on them, and there they are on the kitchen floor. Well, they too have lost their thermoregulatory mechanisms, and subsequently they can come into a septic, but with temperatures in the 94 degree Fahrenheit or 32 degrees centigrade areas. And so as I start to warm them up, as we start to warm them up, we start figuring out that, hey, this patient's got something else going on here. And so whether the sepsis and lightheadedness, dizziness, and the hypotension came from the it resulted in the fall, or the patient just slipping down onto the floor, or whether it's that was the cause of their fall, you'll never probably be able to figure that out. Subsequently, when you pick these patients up off the kitchen floor, there could be an MI associated with this. But for the hypothermia, the patient was never able to call for help. So getting into a little bit of pathophysiology now. Thermoregulation, when it comes to heat production, it's a bad thing to study. Some of the algorithms that are out there as to how thermoregulation actually comes about involving the anterior hypothalamus can be quite difficult to understand unless you really sit down and learn it, except to say that the hypothalamus is involved, and subsequently they can trigger hormone release, which can stimulate the body to autoregulate or produce its own heat. And really, in the most important area of heat production that we have is stamping your feet, jumping up around, such like that. But then when you really get cold, you get a shiver response. And it's the shiver response that can raise your basal metabolic rate 2 to 5 times what it normally is. Subsequently, when you see a patient shaking, at least you've caught them in a mild hypothermic state and they're still able to shiver. There comes a time when they get moderate to severe hypothermia where the shiver response stops. When that happens, we got ourselves a bit of a problem here. But when you see somebody actually shivering, you know that they're hypothermic, and it's time to start rewarming strategies. So when you think about how do we keep warm, the body will recognize that there's a hypothermia going on. You've got receptors in the kidneys, the heart, and the chest and abdomen. And subsequently, when it determines that core temperature needs to be preserved to keep the vital organs functioning, the periphery starts to shut down. That's why they look like they have pale, maybe even bluish skin and such. And when you touch their extremities, they're extremely cold, but they're very pale. You can barely get a capillary refill response. And sometimes when you do, that could be over 5-6 seconds. Vasoconstriction occurs at the periphery as a result of alpha stimulation. So there's going to be a peripheral response to an epinephrine type of hormone that's being released that's shutting down the periphery, alpha stimulation. And what's that doing is it's squeezing the blood out of the extremities and keeping it in the core and trying to thermoregulate a smaller space. In other words, the head, the chest, and the abdomen, rather than trying to warm up the entire body. So this is a more serious situation when the periphery starts to shut down. And as a result of that, then that's when you start getting frostbite and such to the extremities, that it vasoconstricts. It can no longer put blood out into the periphery anymore to warm them up. The sacrifice is to keep the brain, the heart, and the kidneys functioning. Now, this is strategies for heat conservation as opposed to the previous slide where the shiver response is actually heat producing. So to understand what's going on in the body when it comes to hypothermia, you have to understand why the body's doing what it's doing so that you can understand how the rewarming strategies are going to apply in a certain situation. And of course, you have to be aware, just like anything else, either you're not producing enough or you're losing it too quick. The best analogy I can give you, if you're bleeding, GI bleeds, are you bleeding too quickly where the body can't keep up with production? Or like in the case of sickle cell anemia, you're not producing enough blood to begin with. Either way, it leads to anemia. But knowing if it's a production or if it's a conservation issue will help you apply the appropriate rewarming strategy. All right, so when you get impaired thermal regulation, again, from the anterior hypothalamus, the hormones that are released from there and such, you get, you have to look at the organ itself. The hypothalamus has a couple of large arteries that feed it. It's very ischemic sensitive. We see that strokes, tumors, maybe even intraparenchymal bleeds and such, or even alcohol, can affect the anterior hypophysis, hypothalamus. And subsequently, thermal regulation goes out the window. It's not able to regulate itself. You should also know that when a patient has a shiver or a hypothermia and such, that there are certain medications that can cause this. Now, we're also looking at alcohol, but you're looking at benzodiazepines, opioids, barbiturates, and all the other drugs that you're seeing there. So it's going to be important to realize what's an antipsychotic, what's a tricyclic, what's a phenothiazine. Examples of phenothiazines can be Haldol, and some of the medications that are used to control psychosis or people who are manifesting psychotic feature with their primary axis 1 diagnoses such as schizophrenia and bipolar patients. So anybody who's on any kind of major medication can also disrupt thermoregulation as well. More times than not, with dementias and Alzheimer's and such, you see patients walking in the cold, but you can also see bipolar, schizophrenic patients walking around as well. They have psychotic features, and they're on medications to try and control those psychotic features. Remember, the diagnosis of psychosis is being out of touch with reality. Subsequently, a snowstorm outside, like they're experiencing on the East Coast, a bipolar schizophrenic who has not been on their medications could very easily walk outside perceiving that it's a nice summer balmy day and don't realize until it's too late that they're really in trouble from a hostile environment, such as freezing cold. And of course, we have alcohol. I think we've all kind of sort of been there where you have a little bit too much to drink and you seem to tolerate the cold very well. It's because you're numb to it. You're not feeling it. You've lost thermoregulation through the hypothalamus, so the body still thinks like it's a happy 98.7, when in actuality, you're becoming hypothermic. Now, these patients tend to be mild, but they can go moderate. Homeless persons who drink a lot of alcohol and such could obviously go into severe hypothermia, and these are the good folks that on a cold winter day are found dead in alleys and under bridges and such like that. They've just lost all thermoregulatory capabilities. Now, the subset of patients that I mentioned a little bit earlier in the presentation is the elderly. Of course, they're less able actually to discriminate temperature changes, and sometimes with their dementia or delirium, they can't perceive, or they won't perceive, or they have an altered perception of what's outside, or what's cold, or what's warm and such. And so they get themselves into some trouble both inside the house as well as outside the house. Elderly tend to be found hypothermic inside the house, where they have fallen and they can't get up, or they've moved around the house without taking their medications and subsequently get lost in their own mind within their home, and subsequently get themselves in a little trouble, whether it's the bathroom or the kitchen and such. And subsequently, they develop hypothermia, fall to the ground. And then as the days wear on, dehydration, sepsis, and other things set in, and they're not able to distinguish warm from cold anymore. They've gone past the shiver stage, and now they're into some moderate hypothermia. And this can be problematic because many of the elderly, of course, are on cardiac meds as well, and they can blockade an alpha response. So if you've got alpha stimulation doing some peripheral vasoconstriction to keep the blood inside the core, now you're on medications that could produce alpha blockade, and the vasoconstriction never occurs. Subsequently, they're set up for sepsis, or set up for cardiogenic shock or any kind of shock state. And now we've got ourselves a real problem. It's because of their cardiac medication. So as a result of that, it can unmask whatever their underlying condition was that we were taking the medications for to begin with. Now that disease process comes out as well. Now, as we move into the more systemic effects of hypothermia, keep in mind that most of this is for healthy patients, but sometimes you run into this with the elderly. The cardiovascular effects, I'll get to the next slide here. Cardiovascular effects of hypothermia can be pretty pronounced, but it should be known that your initial cardiac response to cold stress is tachycardia, then progresses to bradycardia. So if your patient's cold outside and you put them on a monitor and they're still tachycardic, you probably got a mild hypothermic situation going on. They just require passive rewarming, blankets, turn on the heat in the back of the ambulance. By the time you get to the hospital, they're pretty well on their way to being rewarmed. Should you run into the patient who's hypothermic, who is bradycardic, now we got some major problems. So one of the ways that you can figure out if the patient is truly hypothermic or if it's a cardiac condition is you give them atropine. I'll give them a 0.5 milligram to 1 milligram of atropine IV push for a heart rate of 30, 35, 40. And if they don't respond and they've got a temperature of 92 degrees, then you've got a pretty good idea that this person's in a moderate to severe situation. So bradycardia is what you're really worried about. Initial tachycardia is a normal response to hypothermia. It's trying to pump warm blood around the body a whole lot quicker. But once you get into bradycardia, we got a bigger problem. And know this for the exam, it is not responsive to atropine. Okay. So on the EKG, you get a 12 lead on these people, and what are you showing here? 12 lead EKG, one of the characteristic findings of a hypothermia is the J wave, or the Osborn waves. And this occurs right after the QRS, before what you would expect the T wave to occur. And it's a nice peaked extra wave that's in there. And typically it occurs at a core temperature less than 32 degrees centigrade. And that's going to be an important number to know. When J waves occur, what would you predict the patient's temperature to be? That kind of sort of scenario. And here's an example of it. The J wave occurs right after the QRS, and it seems to be peaked. T wave is sitting out here some way. It seems to be more inverted. This QT interval is very prolonged, which is another characteristic of bradycardia, but obviously you can see this in just about any disease and most medications that are out there. So whether this or not is significant, it's not known. Prolonged QT, but certainly the J wave is something that you would consider. When you see it, it could very well point to hypothermia. There are other signs and symptoms you're going to be looking for the hypothermia. But bottom line is, when you see this, it's pretty classic for it. Now, does it diagnose it? No. Obviously, the core temperature diagnoses it. But it's kind of interesting to see the J waves. And J waves are always associated with moderate to severe hypothermias. Now, when it comes to hypothermia-induced arrhythmias, first you get the tachycardia. Then you get bradycardia, or you can get atrial fibrillation. So the most common rhythm you're going to get with hypothermia is sinus tachycardia. The most common dysrhythmia is going to be atrial fibrillation. And that usually occurs around the 32 degree mark and such. When you get to 30, 32 degrees, you're going to see these patients going in atrial fib who otherwise have not had a history of atrial fibrillation. So atrial fibrillation is going to be the one that you're most concerned about. Now, if the patient has a history of atrial fibrillation, it's not going to do you any good. The bradycardia may give you a very good clue of what's going on here. But for the most part, the atrial fibrillation is going to be a normal response to a bradycardic response. If you got atrial fibrillation with a tachycardia, you're probably not looking at a significant moderate to severe hypothermia, maybe a mild hypothermia. But keep in mind that once the bradycardia starts setting in, you got a whole new ballgame going on. Now, when we get below 28 degrees, and again, the atrial fibrillation, anything over 32 degrees to about 28, 29 degrees, you get atrial fibrillation. Those are the magic numbers you need to know. When you get below 28 degrees, ventricular fibrillation becomes more likely. And it continues because it decreases the fibrillation threshold. All the cells are just losing their capability to maintain a certain threshold. In other words, a certain voltage of an impulse has to hit me before I beat. And now it's much lower, much lower, much lower, to the point where any kind of stimulation can cause ventricular fibrillation. We get into acid-base disturbances, ischemia, myocardial temperature gradients. All these are great little theories that are out there, but the bottom line is, by studies, we know that the threshold potential, which is high in a normal beating heart, becomes very, very low, to the point where any electrical activity can stimulate ventricular fibrillation. So what do we do? Well, At 28 degrees or below and your patient's in ventricular fibrillation, the American College of Cardiologists and the American Heart Association still recommend defibrillation, but only one time. You shock them once. If they're still in B-fib, you do CPR. You get the airway established, a definitive airway preferably, in other words, an intubation, and you continue CPR until you get them to the emergency department. It's then that the emergency department will start rewarming while CPR continues. And that CPR could last almost an hour before you get to the point where you're warm, where you can defibrillate again, and hopefully for conversion. Now, this is an instance where amiodarone, beryllium, and some of the other medications that were out there that profess that you give it V-fib and hope for a chemical conversion, these drugs are not going to work. Not even the least bit below 34 degrees. And subsequently, you shock once, and if it doesn't convert, you continue CPR and you go into the hospital. That's it. Put the paddles away. Don't recommend anymore. All right, so neurological effects, well, as temperature decreases, level of consciousness decreases. Pupillary light response, deep tendon reflexes, but you should know muscular tone increases. So a person who's got fixed and dilated pupils, who aren't moving around, who aren't making any noises, seem stiff, you can interpret that as death, maybe even rigor mortis. Not true. It's not true. This is the result of patients with a GCS of 3, fixed pupils, stiff bodies. You can still resuscitate these people. That's the beauty of it. Now, if they've fallen into a bank of snow and they have a mouth full of snow and their nose is full of snow and such, I think it's safe to say that they're probably dead. But patients who don't have anything in their mouth or their nose, who are cold, this cold and stiff, they can still be resuscitated. The body's ability to, the mammalian dive reflex, the body's ability to hit cold temperatures very quickly and preserve their demands for oxygen is pretty impressive. When you get down to about 34, 32 degrees and such, maybe even less than that, down to 28, the body's need for oxygen is reduced by almost 90%. And so one breath every couple of minutes gives them enough oxygen to sustain themselves. And sometimes you won't even pick up a pulse. You may get 1 beat per minute instead of the regular 60 to 100 beats per minute. You get 1 to 2 beats per minute. And so it's a phenomenon that quite frankly exists in enough people that this is a very real condition, and you can't give up on these people. You have to continue your CPR all the way into the hospital. The hospital continue their CPR until they warm the patient to a temperature where they feel comfortable either defibrillating and getting the patient resuscitated, or where they actually do call it. So nobody's dead until they're warm and dead. Now, initially, just like you saw with the cardiac dysrhythmias, where a patient goes into sinus tachycardia first and then go to bradyarrhythmias, it's the same thing with the respiratory system. You start out with a tachypnea, and then as time goes on, there's a progressive flowing respiratory rate as the temperature keeps going down. And it keeps going down up until 24 degrees centigrade. Now, you know, anything below 28 degrees can cause ventricular fibrillation. Obviously, that's going to stop all breathing, or at least get you down to a breathing 1 per minute. But the actual breathing, if the heart is still beating appropriately, 1 to 2 to 3 beats per minute, let's say, then there's still a chance that the 1 to 2 breaths per minute is enough to sustain the body in that cool temperature. And so, again, it starts tachypnea, goes to bradycardia, slow respiratory rate, bradypnea, if you will. We don't use that term at all. We just slow respiratory rate is sufficient. Now, the cooling of the respiratory center depresses ventilatory drive with the response to PCO2 stimulation progressively worsened below 34 degrees. That's an actual quote out of one of the books that I researched to make this presentation for you this evening. So what we see here is respiratory centers, which is in the brain stem. Normal respirations are stimulated by a rise in CO2. That's your primary drive. Once a smoker or somebody with emphysema wipes out that primary carbon dioxide drive, then the backup kicks in, which is low oxygen, which is why you don't give a lot of oxygen as emphysemic patients unless they really need it. But patients are usually sustained on 1 to 2 liters per minute who are emphysemic. Well, it's the same thing here with hypothermia. It really knocks out the PCO2 stimulation, and it gets very resistant to that. And subsequently, the low O2 drive has to kick in. Well, guess what? You're only doing 2 to 3 beats or breaths per minute and such. Low oxygen may be all that's needed to keep this person alive, but once they wipe out that partial carbon dioxide pressure, in other words, that primary carbon dioxide drive, the patient then is in real trouble. And of course, with any one of these conditions, moderate to severe hypothermia, with the heart not beating as much as it should, there's a diffusion that occurs. You get water that just kind of moves out of the cardiovascular system, and guess where it sets up? It sets up in the lungs. And you can be hypoxic from non-cardiogenic pulmonary edema. So one of the big points I wanted to make here is that by depressing your ventilatory drive, it's because it has become refractory to high carbon dioxides, and it will no longer stimulate the next breath. It's a very important slide. You'll find 2 points on it, which appear routinely on the exams. Now, we've covered pathophysiology, you covered some definitions, you covered why things happen the way that they do, and what the response is to the body when it's subjected to hypothermia. And we also covered a population of people, both primary as well as secondary, which are subjected to or at high risk for hypothermia. And you'll need to know all this. Now let's get into the paramedic stuff. Let's get into what do we do about it, Doc? And the answer is you're just going to minimize heat loss. Understanding all this pathophysiology and everything that's happened, it's going to come down to this. You got to stop the heat loss. Get them in the back of the ambulance as soon as you can. High heat in the back of the ambulance. Don't blow it directly on them, but high heat, and cover them in blankets. And hopefully somewhere along the line, you get the patient back to some semblance of a shiver response. Don't stop the shiver. Don't give Ativan thinking, that we got to stop the shiver. The shiver is what's producing heat for them internally. So just cover them up. The passive rewarming is what they call it. It's a good strategy for mild to moderate. And subsequently, you have to make a pretty good beeline to the hospital. These are patients that are in some serious trouble if they have a core temperature which is below 34 degrees. This is why paramedics really need to be taking temperatures out there. It can go oral, it can go axillary. I don't recommend the probe that goes across the forehead because there's already an alpha stimulation going on, vasoconstriction, and it's actually pulling blood away from the forehead and such. But some of these paper thermometers that can put under the tongue and such like that gives you a pretty good ballpark where you're at with these patients and what you need to do. But the most important thing, warm ambulance, blankets, and if you need to, intubation to preserve the airway and the patients as well as their oxygenation. And for the VFib patient, 1 shock and CPR into the hospital if they're in severe hypothermia. It depends on what your 12 lead shows. So that's more important. You should know from an electrolyte standpoint that most, if not all, hypothermic patients are hyperglycemic. Subsequently, if you've got a low sugar, you may have another illness or injury at play with this patient that caused the hypothermia. So be watching for sepsises, diabetic ketoacidosis, hyperosmolar non-ketotic comas in patients, stroke, sepsises, brain bleeds, heart attacks. All right, so getting the EKG early is going to be really important. And don't forget your 15 lead. If you got some suspicion going on in V1, V2, make sure you get right-sided leads as well. So here's some caveats, and this that first one is going to be really important. This came off one of the tests that we had, or a derivation from it. But peripheral pulses can be very difficult. I can put my hand on the femoral pulse, the radial pulse and such, and I may not be able to feel anything. I may get 1 or 2 beats per minute. If you put your finger on the carotid or the radial pulse or the femoral pulse and you don't feel anything for about 20 or 30 seconds, you'll interpret this as cardiac arrest. That very well may be that you'll have to pick up CPR somewhere along the line, but know this, that bradycardia came after the tachycardia and the patient slipping into moderate to severe hypothermia. And so active rewarming is going to have to take place, blankets, forced air and such like that, intubation with humidified oxygen and such, warmed oxygen, maybe even preheated IV therapy. And then when you get them into the emergency department, we get even more aggressive with the severe hypothermic patients. But CPR should be started. Don't forget, you get 1 shot at the VFib. You do 1 shock, and then you go ahead and start CPR. This is only after your judgment as a paramedic that you've held on to them looking for pulses for quite a while. This is not to say that you don't start CPR. It just means give it some time before you start CPR, because it may be that you don't have to, and that rewarming will start picking up the heartbeat and such. If you want to give a dose of atropine, just see what happens. It's refractory. If it's not going to do any good, then it's probably moderate to severe hypothermia. If it does do some good, you're dealing with another problem, not necessarily hypothermia. And this is where you keep it nice and clear in your head as what you're looking for. You'll be able to determine whether this is a true hypothermia or if there's another metabolic condition that's causing the bradycardia. All right, as we wind down now, you look for the glucose. Comatose patients where you might suspect, especially in a healthy person, you might suspect alcohol intoxication, but there may be an opioid involved. You may want to give your Narcan just to make sure that nothing else is going on. Nobody's going to have any heartache over that. Narcan is to the point right now where we're giving it to police officers, and they're even talking about selling it over the counter for patients for patients who have any kind of opioid abuse going on. There'll be somebody there to inject the Narcan, kind of looking like an EpiPen, if you will, something where people can't run around with a syringe and needle, but it'll be a Carpiject type injector, if you will. I think that's a good idea. It's got such a high safety profile that you can't possibly overdose on it, and it can save lives. Okay, the airway. As we talk about a patent airway, indications for intubation are pretty much identical to what you would face in a normothermic patient. So it's going to be, are you breathing, are you not breathing? Pulse oximetry is going to be useless. Why? Vasoconstriction is going on. You're not going to be able to see what's going on there. Subsequently, end tidal volume may be very good to helping us with this. But if they look like they're not adequately breathing, if they're less than 6 a minute, I would go ahead and tube these patients. Once you get the IV started, good luck with that. If the vasoconstriction is so pronounced where even the veins are constricted, then you may have a problem with that. So an IO may be your best consideration here. At least you know the bones aren't going to vasoconstrict on you. But somehow or another, get some warm IV fluids into these patients, and you can try your atropine like we talked about. But if the patient looks like they need intubation, you can certainly give your paralytics if you want, your sedative medications, your Versed, your ketamine and such, just so that you don't precipitate a gag reflex. But intubate them the same way you would a normal patient. All right, we know that hypothermia slows metabolism, oxygen utilization, carbon dioxide production are produced as well. Don't overventilate these patients. That was the big caveat that I pulled out of here. Don't get into the 20 per minute kind of thing. Keep your respiratory rate between 10 and 12. There's a reason for that. It's what our studies are showing, to keep a perfect balance of oxygen and carbon dioxide. And especially in the hypothermic patient, may have some myocardial irritability to begin with the atrial fibrillation, or even more severe hypothermia where ventricular fibrillation can occur at any minute, anything over 28, under 28 degrees centigrade. You don't want to be overventilating these patients. Respiratory alkalosis actually raises the probabilities that you can send these patients into VFib. Acidosis tends to be a little bit more cardioprotective than alkalosis. And so we don't want to give the body an excuse going to VFib. Okay, as we wrap this up now, expect the severely hypothermic patient to be bradycardic. This is very, very important. Tachycardia first, bradycardia second. They're slipping and more into hypothermia. Spend 30 to 45 seconds palpating for pulses in the carotid femoral area. Dopplers are useful. If the patient's truly pulseless, go ahead and start your CPR. But only if the paramedic is convinced pulses are absent, completely absent. Remember, the patient's very cold. Waiting 1 minute to feel for pulses is not going to make a difference like it would in a normal thermic patient, where you can start slipping your odds with every minute that they don't have oxygen. These patients are hypothermic. Give it the full 30 to 45 seconds before you start CPR, or at least checking for pulses. And there's slowing of electrical conduction. It can be visualized in the ECG. We got a prolonged QT wave interval. Okay, and the second one is the presence of J waves. So watch for the QT interval prolongation on your exam, and watch for the J waves on your exam. Below 32 degrees, atrial fibrillation is the most common dysrhythmia. And then less than 28 degrees ventriculation and asystole, of course, are of grave concern. And don't rely on pulse oximetry. If one of your choices in a scenario is pulse oximetry, don't take it because of the vasoconstriction. All right, that concludes at least this part of the show. Does anybody have any questions for me?